It's a great pleasure for me to welcome you to this symposium today, entitled Technologies to Prevent Infections in Clinical Practice. The subject of this symposium is very important and has been even more important given the recent pandemic, or ongoing pandemic, I should say, where infection prevention has become top of mind of many people. My name is Stefan Grass, and I'm the Chief Medical Officer of Bactiguard. And together with me today, I have two leading experts in this area. What is important to note is that what we're going to discuss today is not only a future dream, it is something that is implemented in the healthcare system today as we speak. So it will be very interesting to hear the presentations. Before I start introducing the first speaker, I would like to mention that this symposium is done in collaboration with a project called HAI Proactive, and that is a Swedish Innovation Agency fund-driven project focusing on ways of reducing healthcare-associated infections through technology. The project has multiple stakeholders, including Karolinska University Hospital, Norrland University Hospital, and also the region of Stockholm, region of Västerbotten, and also Bactiguard is one of the participants in this project. With that said, I would like to introduce today's first speaker. It is Dr. Anders Johansson from Umeå in the north part of Sweden. He is a consultant of infectious diseases and also head of infection prevention and control at Norrland University Hospital. And he's also associate professor with Umeå University. So it's a great pleasure for me to introduce Dr. Anders Johansson. Please.
I'll begin with a short introduction on the burden of healthcare-associated infections and the burden of antimicrobial resistance. So, what are the consequences? Healthcare-acquired infections are major causes of preventable deaths, suffering, and increased costs across worldwide healthcare systems. And the high problem is becoming even worse because antimicrobial resistance makes drugs for the treatment of infections ineffective. To put these things into context, I took some figures to compare with. The WHO estimated in 2021 that approximately 1.3 million people die globally each year as a result of road traffic crashes. And that is pretty much comparable to a recent estimate published in The Lancet in 2022, where they came to the conclusion that 1.27 million deaths are attributable to bacterial AMR. In 2019, they did their data collection. This is pretty similar to estimates on the burden of high. Estimates from Europe are that it's 37,000 deaths per year from high, and figures from the US is about 99,000, the most recent ones. Although figures are lacking for worldwide data, this suggests that it will also be at least 1.3 million deaths globally from high. The recent publication on AMR is an impressive one. They compared all available data worldwide, and they came to the conclusion that slightly less than 5 million deaths are associated with AMR, and that all the world regions are affected, with most effect in sub-Saharan Africa and South Asia. And the same is believed to be true for high. The burden is greatest in sub-Saharan Africa and in South Asia for both AMR and high, and they are interconnected. And AMR and high are two major global challenges. So what is the goal? The prevention goal is the big one. And we have two facets to work with. One is the big heart of healthcare personnel that really wants to save lives. And that is possible to use in prevention, because there is the goodwill of man can be used to prevent infections. And another facet is the new technological advances that comes with time. And combining these two, the big hearts of humans and the behavior of humans with new technology, is an achievable goal in today. It is known since several decades of research in IPC that the change of human behavior is imperative to reduce infections. So this is a very important start when you think about implementing technology. That change of behavior needs to come with the change in technology to decrease the rate of infections. And everyone who knows humans knows that change behavior is not the easiest task. So what do we demand of these humans working in healthcare when they should make their decisions? Because it's complicated to do the best, because on one hand, the patients need interventions. For instance, they may need catheters. In this case, I did sketch a urinary catheter. So the patient may need a urinary catheter, but at the same time, that increases the risk of acquiring a high. And the healthcare worker needs to make a decision on this. And we believe that technology can not only help the collection of standardized high-end AMR surveillance data, we also believe that the new technology can aid human judgment in a very complex healthcare working environment. So conclusions: prevention of infections will require a change of human behavior. New human interacting technology is available that may help human judgment. And automatization may replace and standardize the collection of healthcare surveillance and outcome data.
Thank you very much, Dr. Anders Johansson, for framing the problem and discussing also or presenting the challenge with human behavior. So we'll now switch on to look at how can human behavior be supported by machine behavior, let's say. So it's a great pleasure for me to introduce the next speaker. It's Dr. Pontus Nauclér, who is a consultant in infectious diseases at Karolinska University Hospital in Stockholm. He's also associate professor of Karolinska Institute. So please, Dr. Nauclér, the floor is yours.
So I will present some of the major findings from the Hyperactive project, which is about automated surveillance and prediction of healthcare-associated infections, primarily using electronic health record data. So the Hyperactive project is a triple helix project consisting of public partners, academic partners, and industry. And Karolinska and Umeå has been one of the leaders in this project, and together with Bactiguard and other industrial partners. So Anders told you some background data about why it's so important with healthcare-associated infections and its association with antimicrobial resistance. So it is important to perform surveillance of high. It's essential for infection prevention and control programs, and to have continuous epidemiological data. And this can be used to inform healthcare personnel, give feedback. It's important to allocate resources. And it's also very important to evaluate interventions to prevent healthcare-associated infections. And one of this could be if you're changing the work process in a ward, you want to know that that's actually reduce the number of healthcare-associated infections. or is it that you introduce some kind of new technological advancement to reduce healthcare-associated infection? Does it actually have an effect? So if we look at traditional high surveillance systems, it's usually done through manual review of patient records, and it's been estimated that approximately 1.5 full-term personnel needs to be used for each 10,000 admissions. And if we put that into perspective, for example, at Karolinska University Hospital, we have somewhere around 80,000 admissions a year. That would amount to almost 10 full-time persons only performing surveillance of healthcare-associated infection. And that money is just not there to be used for this. So we want to increase the efficiency of these surveillance systems. So we can do targeted surveillance of specific wards, for example, or what we have been developing in the Hyperactive project, automated surveillance system, where we actually reuse electronic health record data to automatically identify which patients have a healthcare-associated infections and patient at increased risk. So if we look at, this is a publication back from 2017 by Sips et al. Automated surveillance could be divided into semi-automated surveillance and fully automated surveillance. Semi-automated surveillance is where you have some kind of screening indicators to identify individuals that are of increased risk of having a healthcare-associated infections, and then you do manual review of those. So you still need manual review. What we've been trying to do in our project is to develop fully automated surveillance system. So no manual review, only automatically using the electronic health record data to identify the correct patients. So in the project, we develop and implement fully automated healthcare-associated surveillance system. And we use the ECDC, the European Centre of Disease Prevention Control criteria or definitions to increase the generalizability of our findings. And these ones are very close also to the one developed by the CDC in the US. So what we do first, we develop sometimes using machine learning-based screening algorithms for early prediction of high at the individual patient level. We've developed decision support systems for healthcare workers also, so we want to have this information a feedback to the healthcare workers so they can actually take action on the findings. And within the project, we explore added value of using text information through natural language processing and machine learning. So there are AI components in the project. And we have developed algorithms for sepsis, urinary tract infection, Clostridium difficile infections. We are quite far with also algorithms for bloodstream infections, catheter-related infections, surgical site infections, and hospital-onset bacteremia and fungemia. And before I will show you 3 different examples of this, I can say that we are doing a very interesting project, for example, with surgical site infections, where we're also using the natural language processing to identify free text, and we're trying to translate that from one setting to another together with a Dutch hospital. So we're working both with the language of Swedish and Dutch and see if these are transferable between different healthcare systems in different countries. To do this, we use electronic health record data. We create a data warehouse with electronic health record data stored. We have a secure research database where we use only pseudo-anonymized copy of data from the data warehouse. So it follows ethical and legal framework. We use some additional data from other resources. We do the research and develop surveillance and prediction algorithms, and we validate those algorithms, usually through manual review of electronic health record charts. And then the idea is to feed it back as a decision support for stakeholders, and that's from the individual healthcare personnel up to management boards of hospital or even a region. So the research database that we have access to is based on data from the electronic health record from Karolinska. It goes back to 2010, and we have almost 20 million records in this with data on treatments, radiology, microbiology, free text, etc. It's a huge amount of data that we have access to. So I will show you 3 different examples. One about epidemiological surveillance of sepsis, one about prediction of sepsis, and one about epidemiological surveillance of urinary tract infections. And these 3 have different components in them, but they demonstrate very well what is possible to do. So in this study, we had more than 80,000 individuals or patients at Karolinska University Hospital that were included. We used the newly developed sepsis 3 classification as the one we wanted to detect. We identify that is based on suspected infection, which is based on microbiological cultures and given or administered antibiotics, together with organ dysfunction of 6 different organs. And in that is called something called the SOFA score, and you should have an increase in 2 or more points in this score. And we validate that against about 1,000 patient records that were manually annotated by an infectious disease physician. And we identified that the developed rule-based algorithm had a sensitivity of almost 90% and a specificity of 99%. And that gave a positive predictive value of almost 90%. So we think that this is sufficiently good to be used in clinical practice for epidemiological surveillance. And as of note, only 13% of the sepsis cases actually had an ICD-10 code indicating sepsis. And that just shows that using ICD-10 data or administrative data is not enough to perform surveillance of healthcare-associated infections. And this was published, and there was an accompanying editorial that stated that this is the first publication that actually has developed an automated algorithm for the sepsis 3 criteria in the world. We have then, after that, refined the sepsis algorithm by also looking specifically at the respiratory component. Respiration is one of the 6 components in the SOFA score, and using data from 5 different cohorts, we have identified that actually the threshold of 94 and 90% of oxygen saturation should be the one that gives 1 and 2 SOFA respiratory points. And that was also recently published in Critical Care Medicine. So if we move from epidemiological surveillance to prediction of sepsis, there are many prediction models about sepsis, primarily developed for the intensive care unit. There are not that many that have been developed, as we try to do for this, outside the intensive care unit. So our idea is that the big benefit of such a prediction model would probably be outside of the ICU. It would be in an orthopedic ward, maybe where they're not so used at detecting sepsis patients, and you could then detect these patients earlier to prevent a more severe disease and ultimately to prevent deaths. And what has been done previously in many studies is that they have not so much taken into account how it actually should be implemented in real life. And that is something that we worked a lot on in this paper, which is actually quite tricky. So what we use the training and a validation set to develop the sepsis algorithm. This is done in collaboration with a Danish industrial partner called Treat Systems. The outcome was the sepsis algorithm case definition, as I have presented previously. And then we used the prediction model using a Bayesian network with different features. All of them are structural data, but everything from demographics to vital parameters to clinical chemistry. This has not been published yet, but in preliminary data, if you see on the image on the top, the idea is that you have a patient and you see time since admission, and each time a new value of the features that I presented in the last slide changes, it gives a new score. And you have a threshold, so if you go above that threshold, you can see in red, you get a positive screen. But you will also get many negative screens. That is also important. And you can see how the trajectory of this patient changes over time. And we also have a washout window afterwards, so you can see in gray that you silence the alarm system after they have been positive, because as soon we think that for one of the major issues with warning system is what is called alert fatigue. So you get lots of positive warnings, but you will only need to act on some of them, and then it's a little bit like the story of cry wolf. If you cry too many times, you will no longer listen to the cry. And what we showed on the lower images is that it actually performs better than the currently used new scores with a better performance. And if we look at the sepsis finder, in a median time of 50, it identified sepsis cases about 15 hours before the actual sepsis case occurred. And with the currently used news system, the median time was 2 hours before. So we think that we are on something. We don't think it's good enough to implement yet in the clinical setting, but we have some very interesting results. And then the last example I will show you is on the UTI algorithms for urinary tract infections. And why do I want to show that? I want to show that because it's an example of how we used free text. So we developed 5 different algorithms. One was based on only a positive urine culture. And then we added on ICD-10 codes for urinary tract infections, so administrative data. Then we checked also if we could use specific antibiotics for the algorithm. But then we also added on fever and/or UTI symptoms from free text. So this free text is written by nurses and doctors in a hospital. And what one needs to remember, it could be something like we're identifying a word like dysuria, which would be indicative of a urinary tract infection. But nurses and doctors will also write no dysuria, so that needs to be included in the algorithm, or they might spell dysuria in several different ways. And then the last algorithm, we also introduced a negation for fever without UTI symptoms to kind of select if a patient had very indicative other information, or for example having a pneumonia, that would be removed. So if we look at the results of this for the different algorithms, what you can see as an example, first algorithm 1, it had a very high sensitivity but a positive predictive value. And algorithm 1 was urinary culture only. It had a positive predictive value of only about 0.4. So 6 out of 10 patients with this algorithm would be misclassified. But if you look at the algorithm 5, that includes the negation of other kind of infections together with the free text information about symptoms indicating urinary tract infections, we had a sensitivity of about 0.67 and a positive predictive value of 0.72, which we also think could be good enough for using in clinical practice. So what we have done, all of this was done in our research dry laboratory. So we basically have a computerized research laboratory. What we've then moved into is integration into electronic health record systems. So what we have developed in the research lab really has an impact for patients, for the healthcare system. And we've developed something which we call patient safety surveillance system, or patient safety surveillance so the patient safety surveillance system. And these algorithms are cloud-based. But what is important to remember, what we want to do, we want to develop a system where we have a central algorithm, but for legal purposes, we cannot take patient data out of the caregiver's internal environment. So all the data stays for caregiver 1, caregiver 2, and caregiver 3 within their internal environment. But the algorithms are a cloud-based service. And then we can from that produce reports to hospitals and healthcare personnel. And it's a backend algorithm source, it's cloud database, and now I will show you online actually how it works. So this is the demo version of the P3S system. So what you can see here are overviews of how many sepsis 3 cases there is in a region over time. We have how many catheter-related infections there are over time. You can put it in different views. You can show a region, a hospital, or a single unit. You can have information on the back end of what the algorithms are. So currently in the system we have the sepsis 3 epidemiological surveillance algorithm that I've shown. We have algorithms on catheter-related infections, which I have not previously shown. And we also have an algorithm for the SOFA score. And what is important when these are implemented in different hospitals, and currently we have this system implemented in Region Västerbotten in 3 hospitals, as well as at the Karolinska University Hospital. It's important to show that we have developed this algorithm in a research environment, but we need to show that they perform as well in real life. And then we have developed the validation system. So the idea is that when you have introducing a new algorithm, you have some healthcare personnel doing an internal validation using the real world data for patients to assess, does this algorithm actually perform as well as we've done before. So first what is done is there is a local mapping done on the background data, and then a manual validation of this. And according to our what we know so far from the introduction, this is usually takes 1 to 2 months to do the mapping and the validation. And you can put up your own projects here. So here you have for the sepsis 3 project. And then if we go back to the main view again, you have statistics here, as I shown, and you can have feedback on specific patients then that have developed sepsis. So you can go back and check what was done wrong. Is there something that can be improved? So having shown that, I've shown you today the work we have done in the research laboratory, the development of these algorithms, from rule-based algorithm using natural language processing of free text to also machine learning and prediction models, and how we can actually implement these in hospitals, which is currently being done in 4 hospitals in Sweden.
Thank you very much, Dr. Pontus Nauclér. You have given us a glimpse of the future, but as I mentioned in the beginning, it's not only the future, because this algorithm is actually running live in the region of the north part of region of Sweden, but also probably currently will soon be live in other regions and hospitals in Sweden as well. So now we heard a little bit about what the algorithms can do for us in healthcare system. Now we have Dr. Anders Johansson again talking about implementing this as we speak today, because it is not just about creating something, you need to implement it in the clinical routine. So back to you, Dr. Anders Johansson.
Thank you. I will share with you some experiences of the implementation of e-tools for infection prevention and control in healthcare. And the research performed by my group has been done in Region Västerbotten and Umeå University. So these high proactive projects have been focused not only on the development of algorithms, we also have researched methods of operation, the working methods to use these new tools. And we have also explored if we can use such tools as educational packages. So we wanted to create a surveillance concept bridging from population level to the individual patient. And we want to use the fact that healthcare personnel universally want to make good, not bad, for the patient. And we want to modify the risk of high as the moment of meeting a patient. So the goal again is to slightly change the behavior of healthcare personnel to take the optimal decisions with regard to prevention of high at every time point. So we want to reach a behavior change in the end. And a first step was to create a demonstrator for a visual interface for risk estimates of high. And we developed such a tool that later we have actually used very much for educational purposes. And the basic idea was to create this kind of simple green, yellow, red light symbol. So a high meter, you could state it. And we needed some data to load the algorithm with, and we used old style data. That is the traditional way of collecting high data. That has been to manually collect data in a single day and do that all across hospitals. And we had many years of such surveillance to rely on to create the background for this algorithm. So we used data from 2008 to 2015, and then filled in this with data from 2016 to 2018. And that made a total of more than 16,000 patients, and they were registered then in a manner that we could distinguish if they had a high or not, and that this was done with strict criteria. And this was a good basis to by traditional methods create a regression analysis. We used multiple logistic regression methods for modeling the overall risk of high. And the data I talk about is from the northern part of Sweden, where I work, and the previous talk was from Karolinska University Hospital in Stockholm, the capital of Sweden, shown on this map to the right. So the underlying data is such things as what is the age of patients, and this is shown on the left figure. And as you can see, the majority of patients are old. They are more than 60 years old. And the median age is over 70. And it's slightly more females in a hospital, in Europe at least, than it is male patients. And the kinds of high of healthcare associated infections these patients may have is a range of different infections. And the most common kind of infections are pneumonia, cystitis, skin, soft tissue and skin infections, and sepsis and pyelonephritis. And bone and joint infections are also pretty common. So we used this data to make calculations on what is the risk at population level. And by doing this analysis, we could identify risk factors that all of them actually have been previously described, but they were replicated in our data set. Things like if you have a venous catheter or not, what gender you have, if you're in ICU or not, if you're on immunosuppressive therapy, and several other risk factors were identified, and we could put a number to each of these factors to make an algorithm to predict high then. And we decided to set the sensitivity to 90%, and that was done at the cost of over-prediction, of course. With this old style prediction models, we have a pretty much over-prediction, but that wasn't important to us this time, because we wanted to use it as an educational tool rather than a need for being specific and being used in patient care. So we divided then all these 16,000 patients into different risk groups, and we decided to put 1/3 of patients in a green low risk group, and then we had an intermediate risk group in yellow, and then we had a red group with a high risk of high then, and then in the end we wanted to show in this visual tool what risk does this individual patient have. So this is the tool that we had used very much now for educational purposes the last years. So this is something you can have on your mobile phone if you're a healthcare worker and are to be educated in IPC. And then you can fill in on your mobile phone or your computer different kind of risk factors. So this is a manual thing right now for educational purpose. For instance, you could put, does this patient has a urinary catheter? Then the risk is increasing to the right. So was it a recent surgical procedure that will increase risk even more? And then do you have a venous catheter, a central line that will increase risk even more? And then it depends on what kind of hospital you are in. If you're in tertiary care hospital, the risk will be higher as compared with in a secondary care hospital. And then you can modify all these risk factors, and depending if you're on immunosuppressive drugs, then the risk is very, very high. And in the end, if you're in a cancer ward, it will be, or geriatric ward, it will be higher than at a medical ward, for instance. So in the end, we want to make this automatic, of course. The collection of data will be done automatically, but this we know by now that it works perfectly fine for educational purposes. User experience we collected from this when teaching using this tool, where everyone has it on their own mobile phone, is it's very easily integrated and it's very fast to use for educational purposes. And the visual communication is straightforward and needs very little explanation when you do education on IPC for healthcare personnel. And it's a very intuitive explanation of patient risks when adding multiple risk factors. It's very easy to understand when you have more and more risk factors, the total risk for this particular individual will increase substantially. And it gives immediate feedback by a visual signal to the user then. And there is also some fun factor that is appreciated by the large majority of users. But then I have to admit that a few users do not like playing with their mobile apps at all. And maybe we could not reach these very few people. Then I tell you a little more about implementation of another e-tool. This is an e-tool that has been implemented nationwide in Sweden. It's named the infection e-tool, and it's integrated into electronic healthcare records in many hospitals in Sweden. It was launched in clinical use in 2012. The earliest adopters started at that time point. At my hospitals, we started in 2012. And this is an e-tool that was developed to monitor high incidence and initial antimicrobial drug prescriptions for all infections where a physician starts drug treatment. So that's the sort of signal for collecting information. It is when a physician prescribes an antibiotic, then then something happens. Then the system starts to collect information about that treatment. And the underlying philosophy here is that the e-tool is a nudging instrument, and it's created to remind the prescribers of that HIES exists, and it's designed to promote an active choice of an appropriate antimicrobial drug linked to a specific infection that the physicians have to state what is the infection I'm trying to treat. And the tool adds approximately 30 seconds extra work when prescribing an antimicrobial drug, but only at that time point. All other data collection is in the background. And this infection tool is constructed like this. It's a mandatory input from the prescriber where a screen comes up where you have to choose as a prescriber what disease, what infection am I trying to treat? And then it's automatically registered the drug you are prescribing within the electronic healthcare record system. And then in the background, it's automatic collection of a lot of data, like does this particular patient has a catheter? When was surgery performed? And if surgery was performed, all the ICD-10 diagnoses are collected, admission dates, discharge dates, and more laboratory data, etc., is collected automatically. So what's entered actually by the physician is the prescription reason. And then the system contains also a web-based reporting tool that provides customized feedback. And this, as in the example given previously about Dr. Nauclér, this information can be provided at different levels of the organization, from the top down to the ward level. The feedback can be given. So if you look at the national, as a national level, multiple healthcare providers are connected to the same system then, and the tool is connected to the EHR, to the laboratory system, and in some cases also the administrative system when admission dates are needed from that kind of system. And then different healthcare providers provide data to a national database. But importantly, every hospital that integrates this needs to do that locally, because different hospitals have different EHRs and it needs a local adaptation. And importantly, there is a secure login system. So it's needed electronic identification card that makes this system secure. And we use a system that is used throughout the healthcare sector in Sweden, named as SITS card. And importantly, again, data access is restricted. You can access only your own reports. And there is a restriction on each user on how much data you can see. This is an example report directed to a hospital director at the 3 hospitals where I work. And in this image, it's simply shown how many highs per 1,000 patient days have there been the last 3 years when this data was presented for the CEO of the hospital. It's 2019, 2020, 2021 then. And the university hospital is hospital 1, and you see a decreasing trend of high these years, and the same for hospital 2, which is a smaller hospital, and hospital 3 is more variable. So this is just a very simple example, but you can do this also on a detailed level, on an individual diagnosis. What are the pros and cons of the infection e-tool? One probe is that the prescriber is forced to make a decision on what infection he or she intends to treat. And that's an antibiotic stewardship effect, and that's aimed at fighting AMR. The less antibiotics in excess, the less AMR. And it's fairly easy to use, although it takes about 30 seconds extra each time you have to prescribe an antibiotic. And it also serves as a reminder of high and the existence of high, because every time you see and you have to choose, is this a high or is it a community-acquired infection when you prescribe antibiotics? And it's easy to communicate with end users because there is an ownership. They sort of entered their own data and they rely on the data because it's their own data. The cons of this system, one con is the high definitions are blunt, and they cannot be too many. So the actual accuracy is more uncertain because it's totally dependent on what is the knowledge of the end user that decide if this is a high or not. If that end user, that physician is not very knowledgeable about how to define a high, then the data will not be very good at that. So then it means you need to educate all physicians using this system. And that take a lot of resources, of course. And high diagnoses are not tailored for all the different kinds of users. Sometimes some Some wards may have less enthusiasm because they don't find the diagnosis to select among being their favorite diagnosis, infection diagnosis. And it might be difficult to compare healthcare organizations because there is different user cultures in different hospitals. That has been clear when we have compared data between hospitals. So it performs different in different hospitals depending on how educated physicians you have in using these systems. A visually communicating e-tool functions well for high education among healthcare workers. It's easy to relate to individual patient risk using such a visual tool. And our idea is to, in the end, integrate this into the workflow in front of the patient and preferentially integrate it into the EHR system in itself. And finally, an e-tool for digital nudging of antimicrobial drug use and monitoring was successfully implemented, and we have validated it, and we have integrated it at large scales in the workflow of physicians using multiple EHR platforms at very many hospitals in Sweden. And then my last word is, we can't stop here. We also need to scientifically evaluate the effect of these new interventions in healthcare. Thank you very much.
Thank you very much, Dr. Anders Johansson, for this interesting presentation. Especially the power of apps and nudging seems to be very promising. So I think that's probably part of the future as well. Thank you very much. We will end this symposium by me having a presentation about surface modifications that reduce the risk of device-related infections. And I'll just borrow your clicker. So these are some of the data that Dr. Johansson already presented. Healthcare-associated infection, or HAI, is a huge problem that is very often underdiagnosed, as we also heard from Dr. Nauclér working with the algorithm, that only a fraction of the true healthcare-associated infections are actually diagnosed. This is data from US that I think Dr. Anders Johansson presented as well, claiming that around almost 100,000 cases of deaths per year in US are attributed to HAI, and this actually qualifies HAI as one of the top 10 major causes of death, if you look at the American data at least. And there are, of course, huge costs associated to this. In Europe, 7 billion euros, and the same rough number in US, but in US dollars. And we see the connection to antimicrobial resistance here, which also Dr. Johansson presented. Several of the bacteria that are causing healthcare-associated infections are actually resistant, but also, of course, one infection prevented here is also one antibiotic treatment less, so it's also linked to the AMR here. And it is stated that medical devices are a common cause of healthcare-associated infections. This is a report that is quite comprehensive, published by WHO some 10 years ago, where they looked at the worldwide burden of healthcare-associated infections. So the numbers here that you see on the slide is from the developing or the high-income countries. And I just wanted to show you the most prevalent medical device associated healthcare-associated infections. So these are HAIs caused by medical devices, and you can see that the top 3 are catheter-related bloodstream infections, and catheter-related urinary tract infections, and also ventilator-associated pneumonia. And how is the mechanism with when you look at a device-related infection occurring? before I go into that, I want to just to touch a little bit on the prevalence, because the WHO statement was just that a huge portion or a majority of the cases, or at least a lot of cases are of high are caused by medical devices. And there are some old data from 91 suggesting 40 to 60% actually of the highs are due to medical devices. And if you look at the publication to the right, this is also roughly 10 years old from a tertiary hospital in US. And it shows the same type of infections as the WHO report. So it is bloodstream infections caused by catheters, urinary tract infections, and also ventilator-associated pneumonia. And you see the black bars are device non-related. So it's the white bars are the device-related. So you can see over time, actually, the device-related infections in this data set are reducing in the same way as you presented also, Dr. Anders Johansson. So at least during this time period from 2008 to 2012, there is a slight tendency of reduction of device-related infection. But let's remember, this is pre-COVID. And unfortunately, the latest publication from CDC showing device-related infections is quite negative, let's say. If you look to the right, to the left on the table there, you can see the publication from last year showing a quite steep increase in central line associated bloodstream infections, urinary tract infections, and also ventilator-associated events. So from 18% up to 47% increase during the pandemic. So we need to keep a vigilance on healthcare-associated infections, and it is never the right time to take down the guard. I mean, it is something we need to work on constantly. The mechanisms of how an healthcare-associated infection can be related to the medical device. The basis is that when you introduce a foreign material into the human body, you introduce a platform for bacteria to adhere to. So a bacteria floating around in the bloodstream or in the urine is a quite vulnerable bacteria. It can be attacked by the immune system or exposed to antimicrobial agents or antibiotics and such. But bacteria, when they have a platform or surface to attach to, they start colonizing, multiplying, and creating a community, and then eventually a biofilm, which is essentially a protective layer of extracellular matrix type of proteins and compounds that protects the bacteria from immune system and also antibiotics. So that is kind of the basis why a medical device can give rise to a healthcare-associated infection. So, looking at the data you just seen from the prevalence of high and the device-related high, you of course understand that several attempts have been made to modify the risk of device-related high. So, modifying the structure or the surface of medical devices has been there's been a lot of research on that, and to see if you can reduce infections. So there are three main pathways to modify surfaces. One is to make them more anti-adhesive to prevent microbes from attaching. Another way is to make the surface itself active, so connecting some active compound to the surface. And the third way is to have the surface releasing some biocidal substances. If you look at the first one, the anti-adhesive method, so one way is to create a so-called super hydrophobic surface. And that is essentially making, if you look at, this is just a picture of a water drop in contact with the surface. And if you have a hydrophilic surface, the water drop is dispersed over the surface like this, and the contact angle is below 90 degrees. If you have a hydrophobic surface, the contact angle is over 90 degrees, and if you have a super hydrophobic surface, the contact angle is higher than 150 degrees. So basically the water is not dispersing at all over the surface. And it seems that if you have a super hydrophobic surface, microbes tend to dislike that kind of surface. Another way is to modify the morphology of the surface. And this is some quite interesting phenomenon that we see in nature as well. So this is actually an electron microscope picture of the wings of a cicada and the wing surface of a cicada insect or butterfly or whatever. And you can see in magnification that there actually is like nanopillars, almost like very hostile sticking poles sticking out. So you can imagine that the bacteria would not like to attach to this surface. And you see that the picture on the top right, B, you actually see some bacteria that have burst. So they're kind of dispersed and they've been destroyed by this nanopillar surface. So there are a lot of activities ongoing to try to modify. Another way could be to modify the surface by changing the charge of the surface, but also create galvanic effects that I will present a bit later. Looking at contact active surfaces where you actually connect an active compound with a bridge. This could be active compounds such as antimicrobial peptides or quaternary ammonium chlorides, I think, isn't it? Yeah. Other methods could be polymers or bacteriophages, which are actually viruses that kill bacteria. So by having a linker, you have an active compound on the top of the linker. And the third method, as I presented, is the release of active compounds such as antibiotics, chlorhexidine, for instance, silver ions. So the pros and cons of the different technologies is depicted here. If you look at the anti-adhesive pathway, it is, of course, an advantage that it's non-releasing. So it gives you a long duration of effect. And it's also, since it's not killing the microbes, it's not driving any resistance behavior from the bacteria. And also, since it's not releasing, it is also non-toxic for surrounding tissues. The disadvantage with this kind of technology could be that it could be a very complex production. If you remember the nanopillar structure, you can imagine it's quite complex to produce a surface like that. Also could be a limitation in the efficacy. If you look at the charged surface, maybe bacteria with different charges would be repelled, but with other charges might even be attracted by the surface, depending on the bacterial properties or microbial properties. Also difficult to assess the efficacy of this in vitro. That could be a potential disadvantage. If you look at the contact active technology, advantage there is, of course, as the anti-adhesive, it's a non-releasing and it's quite advanced, which is kind of cool if you look at linking different active compounds. But negative that you have a complex production probably, and also the same as with the anti-adhesives, so that some bacterial strains may not be attacked or killed by the different compounds attached. And also potentially it could drive antimicrobial resistance. The last group, the biocide releasing, is maybe the most commonly used because it is a relatively non-complex way of producing. You can just insert a kind of the biocide or the substance you want to release into the surface. So it's quite well proven, and usually you have a well-proven compound, so you have good efficacy, and also easy to demonstrate in vitro. And if you look at the disadvantages with these releasing technologies, since they're releasing, you get the limited duration of effect, and also, of course, it is potentially toxic, since it is not only harming the bacterial cells, but it can also harm the surrounding tissues, but both from a local perspective, but also maybe systemic toxicity. And also, depending on bactericidal substances, it can be effective against some bacterial strains, but not others. And lastly, of course, there is a risk of antimicrobial resistance from the release of the substances. So now I would like to present technology that has been developed by a Swedish company, Bactiguard. This is an anti-adhesive technology, if you remember the previous slide. And it's a non-releasing technology based on three noble metals, gold, silver, palladium, firmly attached to a surface. So it's a non-releasing covalent bond of the underlying surface. These three noble metals, when exposed to minimal amounts of fluid, will create a very small current. It's actually picocurrent. It says microcurrent in the slide, but it's extremely small current, which creates a hostile environment for microbes. So it's the same as a human being touching an electric fence with his hand. So you don't want to keep the hand because you get the unpleasant sensation. So you can imagine the same happening with the bacteria trying to attach. It is agnostic to the microbe, so it doesn't care if it's a gram-positive, gram-negative fungi, or if it's a Staphylococcus, Pseudomonas, whatever. It's the same efficacy regardless of bacteria. And since it's a non-releasing mechanism, it's long-lasting and also not harming the surrounding tissues. So it's effective and safe in this case. The in vitro efficacy of this technology has been demonstrated in different bacterial strains. So these are, it's a bit maybe small letters, but there are different bacterial strains from E. coli, Pseudomonas, and also to the right is actually resistant strains, ESBL producing Klebsiella and MRSA, that have a good reduction of adhesion, so from 60% up to, as you see, 98% there, depending on the bacteria. Also Candida, so which is a fungus, is presented here. So it has efficacy across a wide range of microbes. It's quite versatile, so you can attach this noble metal alloy coating to almost any material, because it's a wet dipping chemical process, so quite easy to produce. And both plastics and silicone, latex, different metals have been successfully modified and surface treated. And the company has focused primarily on attaching this surface treatment to medical devices. There are, as you can see from the products listed here, there are basically the same locations of the body where the most of the healthcare associated infections occur. So it's urinary tract for urinary catheters for urinary tract, central venous catheter for bloodstream, and endotracheal tubes for respiratory tract, and also recently orthopedic trauma implant for basically a surgical site or infections, you can say. The technology has been available since '95 and used in over 200 million catheters. So for being a medical device, there is quite a lot of publications, actually more than 40 published studies, including more than 100,000 patients. And the efficacy has been demonstrated in different patient cohorts, ranging, and the important thing is here that looking at clinical endpoints. So across the cohorts, you see effect around 40 up to 90% in some cohorts, reducing infections, so clinically relevant endpoints. And also demonstrated in different application areas, so urinary tract, bloodstream infections, and also ventilator-associated pneumonias. Just very briefly, the two most recent publications, just to give you a flavor of the technology, this is a study published last year from India. It's 1,000 patients randomized across 5 sites across India, and it's randomized Bactiguard product versus uncoated standard urinary catheter. And you can see in this that it's a 70% almost reduction in symptomatic urinary tract infections. And it is important to note that the primary endpoint in this case is a CDC definition of urinary tract infection, so it's a uniform, globally accepted definition of urinary tract infection. In this case, also no adverse events related to the coating was seen in this study. This study was just published a few months ago, and it is a randomized controlled double-blind study from ICU in Liège, Belgium, looking at endotracheal tubes either coated with Bactiguard technology or standard uncoated. And the nice thing with this study, which is actually a pilot study, is that the tubes, they look identical, so the operator inserting, they don't know which tube is the active and which is the control, and also the evaluator, assessor of VAP, which is diagnosis based on X-ray and microbiology and lab parameters. They don't know which one is the active either. So it's a quite nice design, and in this you see a 53% reduction in ventilator-associated pneumonia, just above significance level P007. However, the time to VAP, it takes longer time for Bactiguard coated, the patients with Bactiguard process to get VAP, so significantly longer time, as you can see on the curve to the right, where it's depicted VAP-free survival. So the blue lines are the Bactiguard coated group, and you can see that it takes longer time for them to develop VAP. Also, there's a tendency of reduced use of antibiotics, P006. And also in this case, no adverse events related to the Bactiguard technology. So short summary, at least 50% of all the healthcare-associated infections seem to be caused by medical devices. So very important to keep track on that. And there are a lot of, as I presented, several technologies to modify surfaces to prevent these infections. Not many used in clinical practice today, but there will probably be much more development ongoing in the next coming years. Bactiguard has developed anti-adhesive surface technology with very good clinical data, and this technology is available on several medical device products already used out in different countries. So with that, I thank you all for your attention, and we'll go over to question session. So I would like to kick off with one more general question, like for maybe for all of us to answer, but maybe start with you, Anders. So what is your vision of the future healthcare system when looking at these new technologies? How would you envision coming to a hospital in 5-10 years and all these technologies available? How will they help the patients in the future and the doctors and the nurses? I mean, how do you see that?
Thanks for this question. I note we actually spoke about all the 3 classical components of infection prevention and control in this session. So we talked about technical hospital hygiene. I mean, surfaces, for instance, and cleanliness and sterilization, and the classical technical. And then we talked about surveillance, which is and now we are developing automated surveillance. And we did talk about human behavior, which is sort of my maybe favorite topic with regard to IPC. And my vision would be then, Stefan, that we would have automated systems to collect information, that we don't need to spend manual time in collecting all this data manually. And we've done that for, since Florence Nightingale's days at the Crimean Wars. She started that, and we need to automatize that. So that's part of it. Another part I foresee is that we have systems integrated with the EHR that aids the healthcare personnel to take their decisions. I think we shouldn't have systems that decide for the healthcare personnel, but we should have systems that integrate the information, provide the information, and preferentially visual, I think, because the humans are made to grasp information visually very, very fast. And in my imagination, we have such systems exemplified by a color system that very quickly collect important information on risk for this particular patient at that particular moment when I make my decision on the fly passing a patient. And then I have a sort of a nudging thing that helps me to take the right decision. That's and it should be in the background. And humans should be first still. The technology will help humans in the background, but they will help us to take the correct decisions. That's my vision.
Thanks a lot. How about you, Pontus? What's your vision?
I think, there's clearly a lot of underused information out there. We're collecting huge amount of data at patients, and it's not used in a very intelligent way today. Us as humans, we cannot grasp and make decisions on such complex data. So we need some kind of help to do that. But I completely agree with what Anders says. I think it's not about machines making the decisions for us, but it's aiding us to make the decisions. It's a little bit similar. There are quite a few failures of the self-driving cars, but you will have a lot of aid in today's cars that indicates, okay, you are now going too much to the right or too much to the left, but it's still your decision to drive to the right or to the left. So I envision that, and I think, there will be more and more decision tools that comes out that aids us to make this decision. And I think what we're developing is part of that, and it can be used for that. I think what will be enormously important, which was what Anders was talking about, is how do we then get that into work processes? And we're just starting that. I think a lot of healthcare personnel, they're not used to using this aid yet, and we don't know how to integrate it into workflows in a good manner. So that is something that will be of importance. And then I think if we can get good systems going that are automating output that is valid, we have the tools to continuously improve implementation of new technological advancement, for example. Because if we're introducing catheters or other medical devices, and we want to know, does it make a difference? I think it was very nice. You showed some very nicely done studies. I mean, we have randomized studies that then they are randomized because then you get the distribution in the two arms of, they are similar, the patients, and that's very nice. But I also think, I mean, we need continuous monitoring. Is there an effect on how, what happens in the hospitals? And I think, I mean, we're just beginning this journey, and I think reusing electronic health record data can aid to do that. But I go back to what Anders is saying. I mean, we need all these different components that was touched upon today, I think, to succeed.
Yeah, thanks a lot. And I'm just very. I like your Anders, your reference to human behavior, because I think it's very important. I mean, we have these very sophisticated algorithms and everything to translate that into action. So collecting data is one thing to make sure that we monitor and surveillance and all these kind of things. But translating it to action, I think it's probably will be the challenge, because the human being is not evolving the same way as the algorithms. I mean, and I think that, what do you think, Anders? What is your thought about the nudging technology in this case to help us make the right decisions, so to speak?
Yeah, I'm kind of attracted with that strategy. And, you know, I think it comes from the economy field in the beginning, but it's sort of the essential is that it should be easier to take the right decision, but still it's your decision and you can decide whatever you want, and there is no one deciding for you. And nudging rather help you to take the best decision for the patient, but it's still adjustable, and I like that. So nudging to me is something that we should strive for. So sort of not a blunt tool that tells the humans what to do, rather a tool that collects information in a better way than we can do ourselves, and analyze the information, and then make that analysis available for the human to take the decision. But I think, as Pontus was talking about, there must be a lot of research done before we know how to construct these nudging things. Yeah. Meanwhile, I think we have to sort of enthusiast people the traditional way. We need to educate people, we need to talk with each other, we need to let them decide on their own environment, to engage people. That's imperative to get things change, I think. And then we should, along with this, we should use these new technologies. For instance, the ones you mentioned by antimicrobial surfaces and other ways of preventing infection transmission. That should be used alongside with these other parts of infection prevention and control.
What do you think, Pontus, in 10 years from now? How much is it possible to reduce healthcare-associated infection? I mean, could it be like you talk about the vision zero of road traffic accidents? Is it even possible to come to zero, or?
No, I don't think so. I mean, it is, as with road accidents, it's not possible to come to zero, because there is a danger in driving a car or walking or so forth. But I mean, there is a lot of data trying to estimate what is possible to reduce. And I mean, that varies from somewhere around 30 to 60% and so forth. And at the same time, the complexity of our patients today is increasing and making them more vulnerable to infections. I mean, and there's been a huge shift just in the last 20 years of the complexity of patients. I mean, many patients that maybe have their third or the fourth cancer diagnosis that they're treated with. So I mean, and that makes them we use more and more aggressive therapies to suppress immune systems. At the same time, I mean, you were mentioning antimicrobial peptides, for example. That is something that I think can be very, very interesting. That in combination with all these other tools, I don't know, maybe 20–30% is a more kind of realistic figure. That's what I would expect.
Yeah, maybe we should look more on the absolute numbers because, as you say, if the patient population in the hospital is getting more severely ill, then maybe the percentage will be the same or even increasing. But the whole hospital is full of very, very ill patients, so it's okay. We could keep on talking for the entire afternoon and evening because this is so interesting. But I would like to end the discussion now, and thank you so much for your participation. Thank you, Pontus. Thank you, Anders. It has been a pleasure to discuss with you and to hear your thoughts on the future. And I think it felt good to get a little bit glimpse of the future, but also know that the future is here. So, thank you very much.